A very good morning to one and all. Today we are going to see about pain control in endodontics. We all know that for ages people are scared of dentists because of the pain which they by themselves undergo because of any toothache, and even if they come for treatment, they're also scared that the treatment will cause pain. So, uh, if we use correct techniques to control pain, it is possible to deal patients in a comfortable zone. So, coming to pain. What is pain? It is the most common complaint in dental treatment, and it is defined as an unpleasant sensory experience initiated by noxious stimulus and transmitted over a specialized neural network to central nervous system where it is interpreted as such. Now, coming to pain, there are two types. One is of odontogenic and non-odontogenic. Odontogenic are pains that is caused because of the problem in the tooth, and non-odontogenic are caused because other than tooth issues. So, under odontogenic, it can be because of the carious tooth or hot tooth, flare-ups, which happens in between the root canal treatments, uh, and such odontogenic pain are localized. They patients give us a correct history of, they'll pinpoint that this tooth is painful, and such pain can be relieved once LA is given. Non-odontogenic pain are associated, could be associated with headache, or sometimes the pain from the sinusitis or from the nasomucosal region will radiate, and it will mimic as a pain in the maxillary posterior tooth. But if we see the etiology, it would be sinus. Also, myofascial pain, neuralgia, herpes zoster, where the pain precedes the oral lesions. In such areas, also such conditions, also patient will have pain in their oral mucosa. Also, psychogenic toothache, where there is no issue in the tooth, but then person says I have a painful tooth. Apprehension and fatigue, all these leads to non-odontogenic pain. Now, coming to the terminologies, we need to know what is acute pain, allodynia, atypical orofacial pain, hyperalgesia, and hyperesthesia. We'll see these things in detail in upcoming slides. The physiology of pain, we all know that cranial nerve 5, uh, it carries the sensory nerves, and it is distributed into three pathways which covers the whole of face, that is the ophthalmic, maxillary, and mandibular nerve. So to diagnose, we need to first understand like what is the origin of the pain. Is it odontogenic or non-odontogenic? If it's odontogenic, then if the tooth is vital or non-vital, and or the pain is primarily due to inflammatory or infectious process, and if the pain is pulpal or periradicular origin, and also if the tooth has a periodontal component, it's only because of the pulp. So it's again divided into three, like pain that is caused before treatment, during treatment, and post treatment. We need to know when and why, because accordingly the treatment plan will change. So, to control the pain, there are three methods. One is psychological, pharmacological, and non-pharmacological. Under psychological, we can inform the patient beforehand what we are going to do, and also do counseling and show them education models or videos, and explain them and make them comfortable. Pharmacological procedures are wherein we give local anesthetics before we start a root canal, or tooth caries removal, and also it is sometimes we can also give NSAIDs before starting the procedure, the day before, from the day before, so that patient will not have pain, and opioids, anxiolytics, sedatives, muscle relaxants. In non-pharmacological methods, if it's going to be orofacial pain because of non-odontic increase in some jaw exercise does help, and also oral splints. If it's in, there's going to be an swelling with pus, we can do incision and drainage. If it's going to be caries involvement, if there is pulpitis, then we can do a pulpotomy or pulpectomy. So, preoperative pain, when patient has, we need to take a proper chief complaint, and a complete medical history and dental history is necessary to rule out the unnecessary, to rule out the differential diagnosis. And also, we need to do a clinical examination, do periodontal probing, periapical test, pulp test. We also need to take a radiograph. So, to effectively manage acute pain, we usually prescribe analgesics. NSAIDs are given before the particular treatment is started. The rationale behind using such analgesics are, it is to block the development of hyperalgesia by reducing the input from peripheral nociceptors. For those who cannot take NSAIDs, we can give them acetaminophen. And patients can also be pre-treated 30 minutes before the procedure with NSAID or acetaminophen. So analgesic strategy, if it's going to be mild pain and patient is NSAID tolerant, then we can give ibuprofen. If it is moderate pain, we can give ibuprofen and acetaminophen. If it's severe pain, we can give hydrocodone and ibuprofen. For NSAID intolerant patients, in case of mild pain, we can give acetaminophen. And if it's moderate pain, acetaminophen and codeine can be given together. If it's severe pain, combination of hydrocodone and acetaminophen is preferred. And for anti-anxiety drugs, diazepam can be given 30 minutes before the treatment. So local anesthetics is again divided into short duration, intermediate duration, and long duration. Depending upon the anesthesia required, we can choose whichever we want. And how to, there are different strategies used to get a profound anesthesia. Sometimes in case of hot tooth, we need to use long acting anesthetics, and also different injection techniques are preferred. So we will see in detail of how to attain profound anesthesia. So here we can use alternative solution. Instead of lignocaine, we can use prilocaine with epinephrine. And also in case of mandibular block, instead of inferior alveolar nerve block, we can try Gauguet's Akinowski technique. And also other alternate primary techniques are EDA and TENS. The supplemental injections can be given, such as when we first prior give an injection, we can apply a topical anesthetic, leave it for 1 to 2 minutes, and then use the needle of 27 or 30 gauge to inject. While giving injection also, we need to slowly give, like at the speed of 1 minute per cartridge. If otherwise, we can also use two-stage injection, where first few drops are left on the mucosal surface to obtain regional anesthesia, and then penetrate and give a block. Other types are intraligamentary anesthesia, which is given in the periodontal ligament space. For this, we need to use short or ultra short needle of 27 or 30 gauge. Only we can drop zero point 0.2 ml of a solution in a periodontal ligament space. When we place it, we first need to check for back pressure and then inject it. The mechanism of action is local anesthesia will spread through cribriform plate into marrow spaces and into vasculature. So the primary route is not periodontal, it is through the marrow spaces which anesthetizes the nerves. We can also give intrapulpal during access cavity preparation. If patient has pain, we can leave a drop of local anesthetic and on over the pulp, and then prick with it with a K file to give the intrapulpal. And intraosseous anesthesia also can be given with a stabby dent kind of instrument. So we need to know when and in which condition what type of local anesthetic technique should be used. So in case of irreversible pulpitis, painful irreversible pulpitis, we can give periodontal ligament and intrapulpal. But in case of apical pathosis, it is contraindicated. There is no use of doing periodontal or intrapulpal if there is going to be apical lesion. So in case of symptomatic pulp necrosis, in case of acute pulpal apical abscess, as we already see, we cannot give PDL or intropulpal. We can use long acting local anesthetics such as etidocaine, bupivacaine. And in case of asymptomatic pulp necrosis, intrapulpal is contraindicated because we might only force the debris and bacteria from the canal into the periapical tissue. So it is better to use only periodontal ligament technique. And if there is a swelling, and we can do incision and drainage. For that we can give block and infiltration anterior and posterior to the swelling to get profound anesthesia. If the patient has intra-appointment pain, it could be because of the mechanical, chemical, or microbial injuries to the pulp or periradicular tissues. It is exacerbated during root canal treatment and even during deep caries management. Sometimes patient will not have pain, but when we do a deep caries management and fill it with IRM or zinc oxide eugenol, and suddenly the patient develops pain, and then we need to relieve it. Sometimes because of the secondary infection, when we do a root canal treatment and there was a breach in a aseptic condition, then also patient will have a pain. It also depends upon the microbial pathogenicity. If the bacteria act in synergism and about the host resistance, extrusion over instrumentation during root canal treatment, and also extended filling uh, will cause pain. So in such cases, the treatment would be like a re-instrumentation. We can give, if there is a swelling, we can do incision and drainage. And if it's because of aseptic environment, then we can place intracanal medicaments. And if there is a apical lesion and pathosis, we can also do occlusal reduction. And also definitely we need to give medication for ease of pain. If it's going to be post endodontic pain, it usually will be because of missed canal or over instrumentation, over obturation, incomplete debridement. In missed canal we have to re-enter and find out the canal. In case of over instrumentation, only medication and relieving from the occlusal stress can help. Over obturation, then we need to reobturate it. Even incomplete debridement, again we need to enter the root canal treatment and do a complete biomechanical preparation. In case of while giving medication, we can check for the type of microbes and then give a specific medication instead of broad spectrum. Sometimes people do say that I have pain in the maxillary molar, maxillary posterior teeth, but not necessarily there should be a problem in the teeth. It could also be referred pain, which we need to know how to rule it out. If patient has a maxillary sinus problem, sinusitis, then it will radiate to the maxillary molars. We can ask the patient, do you have maxillary sinusitis problem, and does it pain when you bow down between your keep your head between your knees? If the pain increases, then we can give them medication for that and ask them to wait and watch. In case of pain, tenderness in the superior belly of masseter, those can mimic pain as in the maxillary posterior teeth, and inferior belly of masseter will have a referred pain in the mandibular posterior teeth. So in such cases, if it's because of muscle spasm or any because of grinding habits, then we need to give patient a proper occlusal splint, or we can also give a botox to relieve the muscle spasm. So in conclusion, pain, though it is an unpleasant, it is a protective sensation. So we need to find out what is the root cause and eliminate accordingly. Thus it is through proper diagnosis and appropriate therapy